welcome to you guys over in the States. This morning or this afternoon for you guys, we'll go through a few of the issues that I see as the top 10, which we've got feedback from. But please, if you have any other questions you want or areas you'd like me to talk about, please just put them in the Q&A panel there, and Kendon will bring those up. We can stop at any time. I'm here to help you guys. We will have a proper Q&A segment at the end. So let's get started. So the very first one was some of the classic findings on freestep. And that's a really good question. Different people will have different points of view on this question. So I've picked three. The first one is the ability to see what's really going on. And that's really important and amazingly obvious with a plantar pressure measuring system, because you can see things that the eye cannot see. So here in the presentation we have in front of you, we have the left foot in the left window, the right foot in the right window, and immediately we can see that in the left foot there is functional hallux limitus because there is high loading. That is, the colours go from blue, green, yellow, orange, red in pressure gradient. So red being the highest pressure, we are seeing pressure underneath the first MTP joint and IPJ of the left foot, which means that both are having a level of pressure and therefore is locking. So functional hallux limitus. We can see how this is affecting the function of the foot, in particular the midfoot, by the little white line, which we'll talk about later, which has got a wave in it, which it shouldn't have, and that the graphs in the middle, the top one relates to the left foot, that there is again in the blue line, which represents the weight or the loading through the rear foot, has got a trough in it. So it's not a nice smooth curve like the green curve is, which represents the forefoot loading. So this sort of information is impossible to see with the naked eye. And this is the sort of information that this program can feed back to you to get an understanding of what's going on in a functional sense. Yes, in a non-weight bearing assessment, we can make some assumptions, but all of the evidence says that the assumptions we make on a non-weight bearing examination can be questioned compared to, is it as valid as a weight bearing assessment? And there's much I could say to that, and if people are interested, I can go into that a bit deeper. So that's my first one. The second is to see postural problems or leg length differences, that sort of thing. How can we be sure what we're seeing is actually happening? You can use high-speed video to look at the asymmetry of hip flexion, knee flexion, ankle dorsiflexion, and make some decisions. You can do again a visual analysis. But this software enables us to actually see it in a dynamic sense. So I'm just going to play a little video. It's quite slow, but you'll get to see the asymmetry between the 2 feet. Okay.
Paul, is it possible to make the slides full screen? We've had it brought up that it's a little small for some.
Okay. Let me see what I can do. Try and make that a bit bigger.
No, I mean the PowerPoint slideshow to fill the screen.
Oh, I'm sorry. I'm sorry. Huh, I'm sorry. Sorry, guys.
No worries.
Okay, so let's look at this again. So here we can see the pressure mapping on either side, either footprint. We can see the right foot is weight bearing through the medial aspect, and the left foot is weight bearing through the lateral aspect. That gives us a bit of a clue that there is a major asymmetry there. The white line, which again we'll talk about later, is what's called the center of pressure, which is an averaging of the body weight, the peak pressure, and the ground reaction force. So at each stage of weight bearing, there will be a point in which the weight travels up this line. And we see these by these two dots here. So I'll play it again, and if you keep an eye on the two dots from the beginning, you'll, let's try that again. It's not what I want. Here we go. So you can see the two dots are going up the line. So at the moment, the right foot is going forward, but now the left foot will catch up. And you can see that the left foot now is screaming past the right foot. And it's that asymmetry that you can start to see where the issues are. Is it the issue or the compensation in the rear foot, in the midfoot, or the forefoot, based on the posture of the foot and of the leg? And if you think that the left foot is working as the shorter limb side, we could put a felt pad underneath the left heel, repeat this examination, and see if the asymmetries we are seeing here change. And this objective data is really very helpful in a number of areas. We can tell our colleagues, okay, this is what we saw, and this is the intervention we did, and this is the result. Or we can do that for an insurance company as well. So that's the second one. The third is the ability to do an assessment, and pretty much what I've just said, then do a repeat assessment either with an intervention or at a later time where various treatments have been done, and see what changes are going on there. So if we have a look on the left-hand view, we can see that the right foot has got a lot of loading on underneath the 4th and 5th MTP joint, with the white line, the center of pressure, having lots of waves in it and ending somewhere around the 2nd or 3rd toe. Not a really good functional foot compared to that of the left foot, which is reasonable. Not perfect, but it's reasonable. So with treatment, when we then reassessed the foot, we could see that there was a substantial change in the right foot, where the weight bearing was much more what we would call ideal and much more symmetrical to that of the left foot. And this is without orthotics. This is after a treatment. So it might be some mobilization of the joints of the foot and ankle. It might be some dry needling by a soft tissue therapist. It might be wearing a pair of orthotics and doing some exercises over a period of time. But this reviewing feature or comparison feature of the software is very powerful and very, very helpful. So that's my classic findings, but I'm happy to talk about any other findings or points of view from anyone else. Okay, so the next question was, how can we use plantar pressure to find a forefoot valgus, or a forefoot varus for that matter? Just like an X-ray doesn't tell you why a person has got osteoporosis or why they've got a stress fracture or an actual fracture or arthritis, it just reports what the X-ray visualizes, or an MRI the same. Plantar pressure doesn't tell you exactly why the foot is working like it's working, but it shows you how it's working and it gives you cues of how it's working. So if we have a look at the right footprint here, we can see that there is a whole lot of loading underneath the big toe joint. We can see, if we look carefully, there's a red line that goes from the heel straight through to the big toe joint, which means that's where the peak pressure is going. So what we could assume from that is that this foot has a plantar flexed, flexible first MTP joint or first metatarsal. So as the weight comes onto the foot, the first MTP joint hits the ground very early and stays there right through the stance phase. So we can assume that either there is a forefoot valgus there or there is a plantar flex first metatarsal there. Of course, this is where clinical assessment is really important, because we need to know, okay, is that the case? How stiff is the first MTP joint? How correctable is it? And again, what we could do here is we could put a felt pad that accommodates the plantar flex first metatarsal underneath the forefoot, and then repeat the assessment and see if this changes the weight-bearing features. Perhaps on the left foot, we could maybe make more of a case of a forefoot valgus, because the weight-bearing goes from the heel onto the forefoot and then focuses right along to the medial aspect of it, weight-bearing through the third, second, and first MTP joint. So if I had to make a decision on this, I'd say that the left one is a forefoot valgus. But it's very risky, because it depends on how stiff the joints are in the midfoot and in the forefoot, how the foot is going to work. So you might have a really rigid forefoot supinatus, I shouldn't say rigid, a very stiff forefoot supinatus, and the weight bearing might be right along the lateral column underneath the fifth MTP joint. Or if there's enough flexibility in the midfoot, the foot may collapse and completely pronate as at late mid stance, which will provide a completely different plantar pressure mapping. And so consequently, we can't, so the bottom line here is you can't define the structure through plantar pressure. All you can see is how the foot is working and work out from that and your clinical assessment what's going on, and then test that hypothesis using the plantar pressure. Okay, number 3, how do we interpret rear foot findings? Rear foot findings I'm taking is the weight bearing through the rear foot and looking at the pressure versus time graphs, which are the graphs in the center, the extra loading of the heel, as you can see. So we can see that the blue line representing the loading in the rear foot goes from the beginning of stance at initial contact almost to the very end of stance. So it's very elongated or very prolonged, the weight bearing, and it is, because of that, it's taking a lot more weight bearing than it should. Ideally, it should be a double hump, and we'll come to that later. So what this means is that either the forefoot is too unstable to take the weight bearing for a long period of time, so that the body has automatically decided that it needs to keep the weight bearing on a more stable rear foot, or that the midfoot has a major dysfunction, that the body doesn't want to place weight bearing or loading through the midfoot structures due to pain or arthritis or some limitation. So the body's holding the weight back as much as it can on a more stable heel area. And so we can see that both in the curves and on the left foot, we can see the the weight bearing through this part of the world here. And so this sort of foot would give talar navicular pain, substantial talar navicular pain, medial ankle pain. This is because the loading is much more prolonged, and so the tissues are stressed for a much longer period of time with every step. This could be a foot that has a very hypermobile foot structure, so it's very unstable through the midfoot and forefoot, or it might be some sort of arthritis or something. Due to the straight center of pressure trajectory, this line here is reasonably straight. There doesn't seem to be any major hesitations or blockages through this line. It's pretty straight. I'd say this person would have a hypermobile foot, and a high arched hypermobile foot at that. We can tell that because there is no weight bearing down the lateral column. It's just in the heel and the forefoot. That I'd say this is more due to hypermobility or poor muscle function and strength. So let's have a look at these double humps of the pressure versus time graph. So they can be called force versus time graph, and that is understandable because we are measuring the loading of the tissues here against time on this side. But with plantar pressure systems, we are only measuring the vertical component of force, not the horizontal. So the vertical component of force is called pressure, and the horizontal component of force is called shear. So no pressure mat can measure shear at present. You need to have a force plate to do that. So we call it a pressure versus time graph. And ideally, we would like to see the loading of the heel or the rear foot in blue and the forefoot in green about 50-50. So 50% of the time on the heel and 50% of the time on the forefoot. That is pretty unusual. It may be the anatomical ideal, but in reality, for a number of reasons, we don't spend as much time on our heel as we do on our forefoot. So around about 50% would be great. The other component we would like to see is a 50-50 situation whereby, well, not so much a 50-50, a symmetry in weight bearing. So if we have the same sort of intensity of weight bearing in the heel to the same sort of intensity of weight bearing in the forefoot. That's the sort of ideal we want. We don't want to have a graded amount in the forefoot to the rear foot. We don't want, and either in the loading in the force or the time that that force has been applied, or that pressure, I should say, has been applied to the foot. So having these ideals are something that we can work towards, and that's important, but we have to recognize that not everyone is going to be able to have those sort of ideals simply because of their structure and their hereditary function. So it would be unusual, for example, for a person with ligamentous laxity to have a nice, stable rear foot and forefoot function because of the fact that their joints can move in a greater excursion. And depending whether they then have genu valgum, tibial verum, or a leg length difference, any injuries through their bodies that requiring compensation, and so on and so forth, it gets to a point where having something perfectly ideal is not just possible. So in that case, we're trying to A, get one foot to be as symmetrical as the other, and B, have it so that it is close to the ideal as a person can be. Number 5, good old plantar fasciitis. With any plantar heel pain, sometimes it can be really difficult to work out exactly what's going on. And know exactly what you need to do with it. So plantar pressure gives us a number of windows to see exactly what's going on. So one of the key features is the elongation of the arch, the medial longitudinal arch, throughout stance phase that creates the overloading of the tissues in the plantar arch area, leading to a high risk of tissue injury, which of course we then causes inflammation and the patient presents with the plantar heel pain. So what we can do here is we can walk a person over a mat and then measure the time of weight bearing between the heel and the first MTP joint. If we look at the right foot, even though it's not ideal loading because there's no loading on the big toe joint, the loading is for a shorter period of time measured by those lines than the left foot. The left foot is a third longer in its loading period. And that's because the medial column is not stable. So when the foot hits the ground and the first MTP joint weight bears, instead of it being stable so that the windlass system can work and all of the other close packing and auto-supportive mechanisms can work, it is unstable, so the ground reaction force can dorsiflex the first metatarsal joint, and in doing so, the arch will elongate. So in this case, what we could do is we could use some sports taping to keep the first MTP joint slightly plantar flexed and stable in that position, walk the person across the mat again and see if that arch elongation timing reduces back to being symmetrical to the less symptomatic foot or the asymptomatic foot. And this is objective data that can be shown to other doctors, shown to health insurances, to actually show that you're examining, you're finding the problem, you are intervening and demonstrating that you are actually fixing the problem. Not just the symptoms, but the actual problem. And of course, if you use, use a low dye technique, you can then replicate that into a pair of orthotics and have a high level of confidence that if the orthotic is plantar flexing and stabilizing the first metatarsal through a number of ways, that the arch won't elongate and the stress will come off the tissues and the symptoms will resolve. Back that up with some strengthening exercises, perhaps some mobilization and stretching, we start to get into rehabilitation and solve the problem. Number 6, why is it that areas expected to have pressure do not always show? I had to think about this one. There's 2 answers to this that I can see. I'm happy again to discuss any potential other answers, but often we've been taught that with a visual analysis, excessive pronation is a really bad thing, and that most people I speak to think that if the foot is pronated throughout gait, the weight bearing will be very, very medial. Well, let's have a look at that. No, that's not what I wanted. Here we go. Okay, so we can see that the foot is very, very pronated and abducted, but the weight bearing is very, very lateral. So here's the left foot, the weight bearing, very, very lateral through the heel, through the 5th MTP joint and out the forefoot. There is some weight bearing for a short period of time in the first MTP joint, which is very, very minor. Here's the right foot again, very abducted, very pronated, and the weight bearing is very lateral. And that's because that's the stable part of the foot. So if the foot is in a functions in a pronated position, the weight bearing is traveling through the unstable part, the medial column. So the body will, by default, immediately and automatically move the weight bearing to the lateral aspect. So sometimes people think, oh, well, if a person's really pronated, we'll expect to see a lot of pressure and a lot of problems underneath the first MTP joint and the medial column. That's not necessarily the case. In fact, it's often not the case. Usually it's through the lateral column and out underneath the second and third MTP joint and out through the IPJ under the hallux, because that's a much more stable weight-bearing pathway. Also, you might have a person who comes in who has plantar callus or has some sort of inflammatory response underneath their forefoot, and when you walk them over the mat, you might see that they don't put much pressure in those areas at all, and that seems to be difficult to understand, because you've got the clinical features of the callus formation, so there must be pressure there, and yet they're not doing that on your pressure mat. Why is that? Well, if it's painful, or it has been painful, they've probably developed a habit of offloading to protect the tissues, and because it hurts. So one of the first things we should be asking our patients as they start walking and as they're getting comfortable in walking before we start recording is, what level of pain are you experiencing right now? And have that feedback. And if it's more than 4 out of 10, the question is, should you do an assessment? Is it going to be valid? Because if they're in pain more than 4 out of 10, they're not going to be walking as they would be without pain. So what you're going to see is going to be a compensated gait, and therefore, unless you're very experienced and you can take that into account, it's going to throw the data away. So maybe provide some anti-inflammatories and then have them come back and have relatively pain-free and then assess. Again, if the condition has been there for a long time, 6 months plus, they may well have developed a compensatory gait habit, and that's going to be even more difficult. So these are the sort of things that you need to tease out in the history so that you can understand what you're seeing. Number 7, what is an effective decrease of pressure in a pathological site? So I've used here a diabetic ulcer as a good example here. There has been quite a lot of research on this over the past few years. I mean, it's been over the past 15 years from David Armstrong and many, many others. But reasonably recently, if I can just check my notes, the International Working Group of the Diabetic Foot has come up with some guidelines. They're available on the web. It's IWGDF Guidelines 2019. It's available on the web. And they've come up to say that the most effective decrease of pressure is to take a pressure area underneath the foot to under 200 PSA. Sorry, PKA. That is 2.3 kilograms per centimetre squared, which is not a lot of pressure. So if you look at a person walking and you use the numerical assessment to actually get the grams per centimetre squared underneath a person's foot, and you have a look at that, and it's over 2 kilograms per centimetre squared in the loading, we need to reduce it down from that. And if a person has had an ulcer, the research says that we have to have a 30% reduction of the pressure or the loading of that tissue to stop the ulcer, stop re-ulceration of that area. So this is based on good research that we can actually say, okay, if the foot has more than 2 kilograms per centimetre squared underneath any areas of a high-risk foot, the chances are they're going to have some problem. Now, obviously, if you've got a healthy 18 to 30-year-old person without any major pathologies, they're going to be able to cope with a whole lot more than 2 kilograms. So we're talking about feet that are at risk at this, in particular diabetic feet. But yes, there is a number, and that is just around about 2 kilograms per centimetre squared measured on the Sensomedica system, or 200 kPa measured in other systems. Okay, number 8. So number 8 talks about this thing I spoke to you about before, and that is the centre of pressure trajectory. So this is a calculation of as the weight travels through the foot, from the heel to the forefoot, the computer looks at the loaded sense cells, which are the little dots that you can see there. Think of them as bathroom scales, and basically looks for the highest reading of those bathroom scales or sense cells, and then works out ground reaction force to take that into account. And from that calculation, we get the white line, which is where the body weight, with taking into account ground reaction force as well, travels through the foot. Now, in an ideal trajectory, we can see on the right-hand side. So there is good research that was presented. It's a bit old these days. It was presented in the 70s, but it is the research we use for the windlass mechanism. And the author, Bojan Mola, talked about the concept of a low gear and high gear axis of the foot. So the weight bearing before I go on to that, so think about a bicycle with the gears. So a low gear makes things easy, but a high gear, when you get going, makes things fast. So the way that the skeletal structure and mechanics are set up is that it's much easier for the body to weight bear through the lateral column of the rear foot. But to go fast, we need to use the mechanics of the first MTP joint in particular, but also the second. And so the weight bearing flows from the lateral heel along the parabola of the metatarsals through the first and second MTP joint and out through the great toe. That's the ideal. Does it happen all the time? Absolutely not. So here's a foot on the left that sort of shows what I would call a reasonable ideal weight bearing. I'm not getting any high loading through the IPJ or the forefoot. I'm getting it through the first MTP joint and the heel. Could there be more weight bearing through the lateral aspect? Yeah, absolutely. So yes, there is an ideal trajectory. There is research behind it. And this is an ideal we try and work towards. Okay, so if that's the ideal, if that's the center of pressure, then what is the normal maximum pressure trajectory? So the maximum pressure, or the peak pressure, is indicated by the red line here. So again, here's a foot with what appears to be a flexible or non-stiff plantar-flexed first metatarsal. So the foot hits the ground. The initial contact is in the heel. So we see the red in the heel. And then as the forefoot comes down, the first MTP joint, as it's plantar-flexed, starts loading immediately. So the peak pressure goes straight to that area and then continues in that trajectory as a person steps off. So this tells us, the peak pressure tells us literally where the peak pressure in the foot is, because it doesn't take into account ground reaction force. Now, what is the normal? The normal trajectory should be similar to that of the center of pressure. It's going to be slightly different with every foot. The actual numbers of the peak pressure, it depends on the foot. But I just want to show you that there is sometimes quite a difference between the peak pressure trajectory and the center of pressure. Oftentimes, with a foot that is laterally weight-bearing, you'll see the red line go straight up from the heel to the 5th MTP joint, and then quickly deviate to go through the 2nd MTP joint and out through the hallux, where the center of pressure will be much more central because of the fact it takes the average of the peak and the ground reaction force. So the peak pressure tells us where the tissues are really being overloaded, and we need to, when we start working out our treatment plans, we need to use that and say, okay, how can we reduce the overloading of those tissues while making the actual pathway of function or the pathway trajectory of the center of pressure, which is much more of a functional assessment overall, more ideal. And this is where, when the peak pressure and the center of pressure trajectory are similar, it makes life quite easy. Okay, so how much time is too much time in one spot? I'll see if I can get this video going, and I want you to focus on the forefoot of the left foot. What's going to happen is the weight's going to come up, and then it's going to really center underneath the 2nd, 3rd MTP joint. I've got this demonstration to show you because the 2nd MTP joint and somewhat the 3rd loads not hugely, but for such an incredibly long time that can cause major problems. So let's have a look at that. Here we are, it's starting to load. We've got loading in the heel, and it comes up into the forefoot, and it starts to load about now, and it continues to load, and the focus on the left foot is just in that area, the 2nd, 3rd MTP joint. Huge tissue loading because of the fact it's there for such a long period of time. And again, it depends on the person and their health. But if this person was a diabetic and they had neuropathy, well, they may not feel this at all. If they had peripheral artery disease, then what would happen is, with the amount of force that's going through that area, it would squeeze what little blood was providing nutrition and oxygen to that area away from the tissues, and it would have hypoxia, and you'd have necrosis starting. And this is what we commonly see, that we have a callus, and underneath the callus we have a very large ulcer, just because of the continual overloading, which the patient is often unaware of because of neuropathy. And this is something that, again, plantar pressure very easily shows this. And again, we can then intervene, remove the high pressure, which should be around about, I don't have the numerical values here, but I would guess it would be in the realms of 8+ kilograms per centimetre squared. We would need to reduce that down to 2. So we could put a felt pad, bringing the pressure into the arch and underneath the forefoot, just to share the weight bearing away from that highly pressured area. When we do that, we've got to be very careful that we don't put more pressure onto another area of risk. And again, this is why plantar pressure is excellent in this. But presented this year was a paper called Measuring Plantar Tissue Stress in People with Diabetic Peripheral Neuropathy. That was presented this year. It's available as a paper, and that looked at three parts of why people continually re-ulcer and are at high risk of amputation. High plantar pressure, which we've just seen, the shear stress, that is the horizontal component of force, and the weight-bearing activities. So they actually found that just because we make a pair of orthotics for the person to wear and offload that area, the patient themselves may not wear the shoes with the orthotics for sufficient time for it to be offloaded. So for example, they might wear their shoes with their orthotics when they go out of the house, but in the house they may just be wearing a pair of socks or a pair of slippers without their orthotics, and of course it's there that the damage is done. So it's far more, like most things, it's far more complicated than just a simple, here's an orthotic to offload the area. We need to be much more vigilant in that. So that's my 10. So I'm more than happy to have any questions. So let me get onto the screen so I can see. All right, so no questions in the Q&A. Kendon, have you had any questions sent to you?
None directly. I'd like to remind you to go ahead and post questions by hitting the Q&A button, and they will come directly into Paul. You can see the questions, right, Paul?
Yep, I can. Okay, so I have one. How much emphasis do you place clinically on the unloading rate? That's a great question. So if I can just go back to a slide so I can discuss that properly. That's a great question. Thank you. Let's just see. Okay. So ideally, again, even though these curves are not exactly smooth and fluid, it should be like a sinusoidal curve. It should go up and down in a symmetrical shape of a curve, as you'd expect. Sometimes the curves will start from nothing and go up very steeply, or from the peak of the curve come down very steeply. And this is the speed of offloading and onloading is significant. So if you have something that gradually loads, then the tissues are able to respond to that, both by the receptors working with the neuromuscular processes and with the joints. But if it is a very steep slope that loads the tissues quick, not only is the tissue loading extreme, the body finds it difficult to deal with that. And so the shape of the graphs, which is something I didn't mention, and thank you for reminding me to do that, is crucial. So if we see something that loads very quickly, that's going to put more loading on the tissue, and we need to find out why. So an example of this would be a child that is going through a growth phase, presenting with Achilles tendonitis or Sever's disease, and you do an assessment, you will see that the loading at the heel will be very sharp, very quickly loaded and very quickly offloaded, and the forefoot will be very quickly loaded and extended. It's those sharp points or those acute gradients that can cause major dramas and major trauma to the tissues. So we need to work out what we can do to slow that loading down or offloading down, because we don't want the tissues to be offloaded quickly as well. So that's a very key point. Thank you. And to answer the question, yes, I look at that very much with acute injuries or tissue overloading of the high-risk foot, because that is crucial in that stage. So that's a very high level of focus in clinical practice. Yeah. Okay, so how much time do you need in a consultation to do the plantar pressure analysis? Another good question. So I'm going to break that down into two parts. The plantar pressure assessment part, you're looking at about 10 minutes. And that is, you have the person come into your clinic in a relaxed state, you've got some history, you've got some background, and then you have them walk up and down the pressure mat so that they get comfortable and confident in doing so. Once they are comfortable and once they're comfortable and confident, that's the word I was looking for, in doing so, without telling them, I'll just start recording. Won't make a big deal about it, just getting them to walk up and down. And I'll take a recording, usually 3 to 4 laps of the mat, depending on how large the mat is. To get enough footprints, I'd like to have at least 4 footprints for the left and 4 footprints for the right, even better 5 or 6. Because when we average them, we want to make sure the data is valid. The analysis then of that depends very much on what you're trying to analyze and your level of experience. And that could take 10 minutes or more. It comes down to systems and experience. And that's where training is a really worthwhile thing, so that you immediately go to the key points and then have an understanding of what is within normal limits versus what is a red flag, and then go through that. And that'll be different from a adolescent with Sever's disease to a young adult who's doing sport, to a pregnant woman, to a person with arthritis or diabetes, to a older person with instability issues. So it's not a clear-cut, cookie-cutter sort of approach, but it can be systemized, and it can be made so that it's not difficult to understand. And ultimately, it comes down to experience. So an experienced person usually can pick up a really good understanding within 5 minutes, maximum. But like with anything, the first time it took to ride a bike, you fell off, it was hard, etc., etc. Now you jump on the bike and away you go. So it's all about practice. Thanks for the questions, guys. I'll try and keep my answers a bit shorter. Can you predict risk of ulceration in an asymptomatic foot? What a great question. Yes, you can. You can take a really good history to get an understanding of their blood glucose control. You can do assessments in a number of ways to see the level of peripheral neuropathy or not. You can do an assessment of their pedal pulses or a Doppler, a toe brachial pressure to get an understanding of the blood flow. And then you can walk the person over the mat and see where the peak pressure is and measure that. So if it's how much more than 2 kilograms per centimetre squared, look at their foot structure to explain why that is. Is the first MTP joint stiff and therefore not working, pushing the weight bearing through the second and third MTP joints? Are they enlarged? Are they arthritic? Are they slightly lower? Is there a forefoot supinatus? To try and understand why the pressure is there. And then look at the integral pressure. So we have average pressure, peak pressure, and integral pressure views. So average pressure, as the name would suggest, is an average pressure over the foot. Peak pressure really focuses on those areas of really high loading, but it may be just for a short period of time. Integral pressure is the key one that we are interested in, because that shows how long the tissues have been loaded. So if there's a really high spot of pressure for a very short period of time, the foot might be able to cope with that. But If it's there for a very long time, as I said, the tissues can be hypoxic and you can get necrosis. So if you saw that happening, you could then say, okay, based on the deformity and the dysfunction of the foot, the peripheral neuropathy, the arterial disease, you're at a certain risk point. And the question is, how can we reduce those risks? And that's where it becomes very valid and very important. Next question: what assessments would you recommend for a chronic posterior tibial muscle tendonitis plus excessive pronation? Okay, so this will depend a lot on the level of dysfunction we're talking about, and of course the patient's history. But the standing on a single leg and then having the patient raise up onto their toes to see if they can do that, hold for 3 seconds, lowering down and repeating that 3 to 4 times is the classic test. As far as plantar pressure is concerned, what I'd want to know is A, how long the heel is weight bearing, so to see that rear foot curve, how elongated is that, because that's a really good sign. Is there medial loading through the arch, which it shouldn't be, so that's another really good sign. And how much is the foot elongating through the medial longitudinal arch, which we talked about in the plantar fasciitis segment. Those 3 things would be my key issues as far as plantar pressure is concerned. Once I'd seen that, I'd say, okay, what can I do to address this? Now, a lot of people who, in my experience, who has post-tib tendon dysfunction or adult acquired flat foot, what a lot of people I see have a large forefoot equinus, so the forefoot is plantarflexed on the rear foot and has been compensated through the midfoot by excessive compensatory pronation, particularly in late mid-stance onwards. And often they have a slightly more mobile range of motion than the average. Not necessarily hypermobile joint type, but a more mobile joint type. So what I can do is I can then say, if I do some stirrup taping, so taking a piece of taping from the lateral ankle underneath the foot to the up over the medial ankle to invert the heel substantially, and then if I see the arch elongation factor, I will actually plantarflex the first metatarsal to make it a stable base so it doesn't elongate and be dorsiflexed. Then I can then review that by walking the person over the mat and see what happens. I do this to make a decision whether I make a Blake inverted rear foot type of orthotic versus a Ritchie brace type of device. So if I can relatively easily manage and change the dynamics shown on the plantar pressure by reasonably simple taping, then I'm fairly confident that a properly designed rear foot device, and when I say rear foot device, I'm talking about a Blake device where the main corrective force is underneath the sustentacular tali, not the talonavicular. I'll be reasonably confident that that sort of device will be effective. If, when I do the taping and I walk the person over the mat and I see that there is little, if any, change, then we'll start to have the discussion that the driver of this may well be the internal tibial the internal tibial rotation as well. So you've got transverse movement of the tibial segment and frontal plane compensatory pronation. So we need to look at something like a Ritchie brace to deal with the transverse tibial rotation as well as the frontal plane pronation. So I use it to actually differentiate where my treatment is going to go with a reasonable level of certainty and confidence, because it's not my opinion here that is I'm taking so much as the objective data feedback. Okay, let's see, is there any more?